Let's finish our last segment now. This is Pediatric Crashing Patient Protocol for Trauma. As we talked about in medical, if you can pull the protocol up, let's follow along together. So let's start off with some facts from dishes about pediatric trauma in Texas. As we said earlier, about 8 to 10% of our overall EMS volume is peds, and about 20% of all pediatric EMS runs are related to trauma. Unfortunately, trauma is the number one cause of death in children, and of those deaths, TBI is the number one cause. About 60% of our overall runs of peds for trauma are related to MVCs or falls. For younger kids, it's going to be typically falls. Remember that a fall greater than about 3 feet can be significant in some infants and small children. And then as we get up into our older children years and into our teens, that's going to be primarily your MVCs. Also, sadly, about 5% of all pediatric trauma is classified as an assault or homicide. So that's divided into two categories. One is your older children that are gun violence, and then unfortunately our smaller age range is going to be non-accidental trauma or abuse. So again, abuse is very common in Texas and our pediatric populations, and so always be on the lookout for it. Let's cover some pediatric versus adult anatomy differences now. First, the kids have much larger heads than adults. And so what you'll see is that they're going to be top heavy and land on the head first, which is a large contributor to the traumatic brain injuries. As they get older and older, the head will become more proportional to the body and more adult-like in nature. Additionally, kids have much weaker neck muscles. And so that huge head can flex and extend back and forth easier. And so what you'll see is more high C-spine injuries in children than adults. However, the pediatric C-spine is much more resilient, and they'll additionally not have as much C-spine fractures compared to adults. The last part of this is the pediatric torso. And so you'll see that the ribs are actually much more flimsy than adults, and they'll actually have some give. And so what you will not have is rib fractures, and that force will be transmitted into the chest, and you'll see much more pulmonary contusion type things. Additionally, the organs of the abdomen are much more anterior, and the kidneys are much more exposed. So they have a higher rate of liver, spleen, and kidney injuries comparatively. They also have less developed abdominal muscles, which adds to the less protection for their abdomen. So our method of approach for trauma in pediatrics is the same as adult. We're going to walk through the MARCH algorithm, addressing massive hemorrhage, airway, respirations, circulation, and then think about hypothermia, mitigation, and head trauma as well. Once we're on scene with a critically injured child, first, take a few deep breaths. Calm yourself down. We all know these are particularly stressful incidents, and the calmer you are, the better you're going to perform. Next, get them on the monitor, get a full set of vitals, and get them on full monitoring equipment, including end-tidal CO2. Expose the patient looking for any injuries, and then cover them up to mitigate hypothermia. Give the hospitals a quick heads up that you're coming in with a pediatric trauma, and then start with the C-spine. Place a collar if they'll tolerate it or they fit in one. If they're intolerant and fighting a C-collar, at least consider inline manual stabilization or some towel rolls to mitigate head rotation back and forth. Let's talk about total blood volume by age. Obviously, it differs. In 30 to 40% blood volume reduction or loss from bleeding is very significant in peds. And as you can see, there's going to be some very small mLs that we lose before we get a large hemorrhage for that child's age. So for a newborn, it's about the size of a Coke can, or about 355 mLs. Think about 30 to 40% reduction in that, and that's huge for a newborn. 5 months olds, about a half a liter bag or 500 mLs. 1-year-olds are about a wine bottle or 750. A 2-year-old is about a liter. 7 and 9-year-old finally gets up to about a 2-liter bottle of Coke. 10 to 11-year-old, you're getting up to about 2.5 liters. And remember that our adults are about 5 liters. Again, children can lose blood rapidly, and that may be a very significant blood loss very quickly. So we're going to get on catastrophic hemorrhage control rapidly. Obviously, we're going to start with direct pressure. If it's a significant hemorrhage, we're going to consider a tourniquet if it's in an extremity. The SWAT tees are great for pediatrics as they're one size fits all for both pediatrics and adults. And so don't hesitate to use tourniquets if you have a catastrophic hemorrhage not resolving with direct pressure. Next, also remember your wound packing, particularly for your junctional injuries in the groin or the shoulders. And then another modification for kids is that the pelvic binders will not fit for pediatrics. So if you do have suspicion for an open book pelvis in peds, consider using a sheet and wrapping that sheet around basically the greater trochanters and then cinching it tight in a knot and holding it there in that way. That's going to be your improvised pelvic binder. So after we've taken those measures, our goal is either going to be met and we've controlled catastrophic hemorrhage, or our exit strategy is basically we've tried our tourniquets, wound packing, direct pressure, gotten a pelvic binder as we need to on, and we've done max therapy per protocol and it's continued to bleed, and we need to rapidly transport that patient in a bit. Next, we're going to establish airway assessment. As far as airway, we need to first think about patency. Kids have large tongues and adenoids and tonsils, and those can easily obstruct the airway as a child gets depressed in their mental status. So first, consider the obstruction and relieve that. So place an OPA, and if there's no signs of head trauma, 2 NPAs in for that child to keep it a patent airway. Next, as we talked about in medical, ear to sternal notch, particularly in the young children, is different. With C-spine precautions, though, we can't use a towel roll and have the body out of alignment. So as you see there, a child basically on a backboard has an angle and their chin's going to be tucked to their chest. And so what we want to do is essentially pad the back all the way to the feet and lift up the torso in line with the ears of the child to place them in ear to sternal notch. So this is how you're going to do it in C-spine precautions to establish an ear to sternal notch positioning. After that, we're going to assess our breathing status. Our first question, just like for our medical protocol, is going to be, are they in respiratory distress or are we in respiratory failure? If any of those are present, if we're in respiratory failure, we're going to start max BVM right away. If we're in respiratory distress, we're going to get maximal oxygen on with an on-rebreather as soon as possible. If we're persistently hypoxic despite max BVM, we're going to consider our quick supraglottic airway right off the bat. Obviously, trauma is a much higher likelihood of a can't oxygenate, can't ventilate situation, particularly for facial trauma. Again, if they're less than 36 kilograms, we're going to do transtracheal ventilation. If we're into our older kids, greater than 36 kilograms or 11 to 12 years old, we're going to start our surgical crike airway for a COCV situation if a king is unsuccessful. As we discussed, there are some differences in the child versus the adult chest. Children have much more pliable ribs, and so they will bend and not break. Unfortunately, the breakage in adults absorbs impact. And so in children, that will transmit the impact further into the chest, and they have a higher rate of pulmonary contusions and pneumothorax. Additionally, the mediastinum is much more easily moved, and their right atrium is more compressed, both of these making tension physiology more likely. So if we have to needle decompress a child, remember that we're not going to use a 14 gauge 3¼ inch needle. There's age specific needle sizing. And so for an age 0 to 5, we're going to use that 18 gauge 1¼ needle. For a 5 to 12, we're going to use a 16 gauge 1¼ to 1.5 needle. Greater than 12, then we get to use our 14 gauge 3¼ inch needle. Finally, if you see any kind of penetrating trauma to the chest and have concern for a sucking chest wound, that's where we're going to use our occlusive dressing. Remember that once you place your occlusive dressing, watch for tension pneumothorax, and if it does occur, burp the dressing or just all out remove it. So once we've done those things, we're either going to met our goal of 94% or greater, or we established an exit strategy of persistent hypoxia where we dropped a supraglottic airway or taking advanced measures of crike or transtracheal ventilation as needed. At this point, we've covered both our hemorrhage and our respiratory goals. This is the primary difference in our trauma protocols from our medical protocols. We're emphasizing an early transport once we've established the things that will kill that child on scene, and then we need to get moving. So we're going to move to the ambulance immediately after establishing those goals. Let's talk about circulation now. As we discussed in the medical protocol, there's age-specific guidelines for hypotension. For less than 1 month old, it's going to be 60. 1 month to 1 year, less than 70. 1 month to 10 is going to be 70 plus 2 times age. And then finally, once we get into the 10-year-old age, it's going to be less than 90, just like our adults. Keep these in mind, especially for our head injured children that we'll go over in a second. Why is intubation and drug assisted under circulation at this point? The whole point of this is, again, that we need to establish, if we are going to choose to intubate a child or do a DIA on scene, is that we need to establish our SpO2 greater than or equal to 94% before proceeding, and we need to get an age-appropriate blood pressure. Keep in mind that that blood pressure that you see immediately on scene may be the best blood pressure you get. They maybe continue to bleed and get more hypotensive. So don't spend a bunch of time on scene attempting to get a blood pressure up to intubate or do a drug-assisted airway. We still need to get that child to the hospital for definitive care as quickly as possible. Let's talk about some time thieves. So these are things like glucoses in an awake and oriented patient, getting 12 leads, doing minor splinting or bandaging, doing non-essential IV or IO fluids, and doing SMR in a penetrating trauma. These are all things that steal your time and delay you from getting off scene and moving to the hospital for blood and other definitive care. So minimize these as much as possible. At this point, let's start transport, and then we do the arrest en route. If you don't need that IV on scene to correct hypotension, do it en route. Do all these things in the back of the truck once we get going. Pediatric hemorrhagic shock is also a little different than adults. So we start off with a blood loss less than 15% of their body. They may have a normal blood pressure, heart rate, respiratory rate, maybe they're a little bit anxious. Once we get into 15 to 30, you're going to start to see tachycardia and tachypnea and a little bit more anxiety. 30 to 40% is getting into a fairly significant hemorrhage, and you're going to see pretty significant tachycardia in a child at that point. You're either see low or borderline normal blood pressures or even a little bit of hypotension. And then finally, they're going to be much more tachypnic, and their mental status is going to be increasingly anxious, or they may start to get confused at that point. Finally, greater than 40% blood volume, this is actually where you're going to see hypotension. So it's going to be very late. At this point, that child's going to be profoundly tachycardic, very lethargic, and very tachypnic at that point. So again, hypotension is going to be a very late sign. Children essentially can't increase their stroke volume. So what you will see is they will kick up their body's resistance and lock down their blood vessels and knock up their heart rate and become more and more tachycardic over time to create as much cardiac output as possible. And so once they can no longer compensate with their tachycardia and increasing their resistance, that's when they become hypotensive. Also note that we should be assessing secondary things like cap refill and pulses to give us a better idea where they're on the hemorrhagic shock spectrum as well. So all this is to basically say is that kids hold a compensated shock for a very long time, and your only clue is going to be tachycardia. Don't blame a tachycardia on the child just being anxious, injured, or in pain. Once you've started to treat those things, especially if the heart rate keeps going up, you must consider that that patient is hemorrhaging and is in a compensated shock that we should start addressing. Once they become into a decompensated shock state, that child is becoming basically peri-arrest a lot of the time. At this point, you should have a clue that permissive hypertension is a big no-no in pediatrics. Given it's such a bad thing, we don't want to tolerate this. And so obviously we want to minimize fluids and not give fluids needlessly, but we must correct hypotension when we see it. Vascular access, as we mentioned in the medical part, is difficult in pediatrics. And so a best way for a critically injured trauma kid who is in hemorrhagic shock is a 1-2 IO type strategy. Start 1 IV, start 2. If you fail both of those, move rapidly to an IO. Since some of these patients may be awake, consider your lidocaine for those patients so they can tolerate it better. It's going to be 0.5 milligrams per kilogram. We're going to infuse that slowly, and then we're going to let it dwell for about 15 seconds, and then we're going to do that hard flush we discussed previously for adults. So if a child is hypotensive or you're seeing signs of poor perfusion or shock, we're going to start out with our standard 20 ml per kilogram IV bolus, and then we're going to repeat as necessary to a goal SBP. Again, we want to minimize fluids as we can, but we need to treat aggressively hypotension or other signs of shock for kids. Generally, kids are going to be fairly responsive to fluids in the trauma situation as well. And in most trauma centers, they'll afford a kid somewhere in 20 to 60 mLs per kilogram before even considering blood in many circumstances. Common question is, for pediatrics, can we give TXA? Unfortunately, the literature is inconclusive for children, and so that's why our protocols reflect not using TXA for pediatrics. In select circumstances, trauma centers may use it for older children, but in general for EMS, it's not a thing right now. So at this point, we've addressed our circulation. We've tried to meet our goals of resolution of hypotension or shock, definitely making sure they're normotensive in a TBI, or we've done our best and they're still hypoperfusing and continuing to bleed, and we've given our maximal attempts at stabilization. Especially for kids, we want to prevent hypothermia. They have a large total body surface area ratio to their weight, therefore they have easier heat loss. Also, they have less fat than adults, and so they lose heat easier that way as well. So remember that hypothermia is part of the deadly triad for trauma, including severe blood loss, coagulopathy, and acidosis. We want to try and minimize this as much as possible, as this is a primary contributor to mortality in kids. We also need to address our Hbombs for head injury. These were the things that were identified in the Excellence in Pre-Hospital Injury Care Traumatic Brain Injury Project, or the EPIC trial. They also included kids in these on the EPIC for Kids part of the trial, and they identified the same Hbombs as adults. These are hypoxia or SpO2 less than 90%, hypotension by age-specific parameters, and hyperventilation for those that are with assisted ventilation. Essentially, we bag too fast. Here's our TBI goals. Again, we're not going to allow any hypoxia if we can help it, so we're going to apply maximal oxygen therapy early. We want SpO2 to stay above greater than 90%, ideally per the crashing patient, greater than or equal to 94%. Additionally, we want to aggressively treat hypotension in kids. Here again are your age parameters. So less than 2, you want a blood pressure greater than 70. 2 to 10, you're going to do 70 plus 2 times their age and keep it above that. And then finally, your 10-year-olds and up are going to be back into the adult range of greater than 90. Your end tidal, you want to target around 40% if you're artificially ventilating, ideally around 35 to 40. Here's our breath rates specifically. For infants less than 2, we're going to target a breath rate of around 25 per minute. Children 2 to 14, 20 per minute, and then adolescents 15 to 17 are back into adult range of about 10 per minute. You don't have to memorize these. We've included them on the trauma page for pediatrics. At this point, we've covered all of the crashing patient trauma protocol for peds, and now I'm going to cover one last thing. This is going to be your pediatric traumatic cardiac arrest page. It looks very similar to your adults as well, with a few differences. First, we did a weight-based dose of normal saline, and then we removed TXA as we discussed previously, and then there's no termination of resuscitation for pediatrics. Those are the only big changes to this page overall. All right, let's wrap this all up now. So at the beginning of this, we did the overview where we talked about the pediatric assessment triangle, which is critical for our primary assessment. Then we talked about some pearls and pitfalls as well. Then we moved into the crashing patient protocol for medical patients. There, we saw that there's some differences in the respiratory distress and respiratory failure definitions, and then we added transtracheal ventilation for the appropriate age range. Then for the circulation part of it, we discussed how there's a difference in our boluses and then our approach to the bradycardic patient. But overall, again, the crashing patient medical protocol is very similar to our adults overall. And then for our crashing patient protocol for trauma, we saw that there's again a few differences for the respiratory section, and then for circulatory, we're going to be a little bit more aggressive for treating hypotension compared to our adults. Finally, the traumatic cardiac arrest had a few small changes as well. So that's all in a nutshell. Again, if you have any questions, please reach out to myself or anyone in the OMD, and I greatly appreciate your attention. I hope this all helped clear some things up for pediatric patients and make you more comfortable. And overall, I hope this improves the care of pediatric patients in our system. Thanks again, and have a great day.